All right. Excellent. So I'd like to thank Holly for inviting me to present tonight and have a discussion about management of urinary incontinence following prostate cancer treatment. I certainly think we are very lucky in Victoria to have the Island Prostate Center as such a resource for our community. And I'm very excited about some of the upcoming sessions because this will build on this bladder control topic. So I'm a urologist in Victoria. I've been here for 10 years now. I did my residency at the University of Alberta and did fellowship training at Australia in functional and reconstructive urology, as well as female pelvic medicine and reconstructive surgery in Dallas. And so here I am a general urologist with a specialty focus in functional urology, female and reconstructive urology. And that means I do general urology, urethroplasties, male incontinence surgeries, female incontinence surgeries, prolapse, prosthesis, the whole gamut. In Victoria, we're lucky. We have three of us urologists who do anti-incontinence procedures, and there's options for that surgery up island as well. And again, a big thank you to the Island Prostate Center. So tonight we're going to discuss, just making sure my head's in the middle of the picture, what urinary incontinence is, the incidence and impact of urinary incontinence, the important anatomy to establish urinary control, the types of urinary incontinence, what we want to know as physicians. So if we don't ask or if something's bothering you, then please tell us that too. Investigations, testing, management and treatment options, and then we'll have some time for questions. So urinary incontinence is the complaint of any involuntary loss of urine. It has a tremendous toll on all aspects of quality of life. It impacts the physical state. People are concerned about odor, can be discomfort, cause chafing, skin irritation, can result in falls and hip fractures on the trips to the toilet. It can cause people to be fearful or anxious, depressed, tired, which then turns into social isolation, starting to miss activities people enjoy, because they're afraid of bringing pads around or soiling the bed. This can interfere with the relationships. It's a very costly condition because pads are very expensive. So I don't think we talk about this problem enough with prostate cancer, but it is a very common problem. So the incidence of urinary incontinence increases in both men and women with aging. The prevalence of urinary incontinence in men is approximately half of that in women, with a range from 1 to 39%. But we typically consider the overall prevalence about 18% in men. So the prostate has a considerable effect on urinary symptoms. So therefore, treatment of the prostate will also impact bladder control. The rate of urinary incontinence after radical prostatectomy ranges from 4 to 72%. And the reason for this big range is it depends on when you ask the person and where they are in their treatment plan, and also the definitions of urinary incontinence. Those vary in the literature quite a bit. The rate of incontinence with radiation treatment is less, about 6 to 7%, and treatment of bladder outlet procedures for benign disease is even less than that, so 1 to 5%. So when we talk about urinary control, the bladder plays a big job. It has 3 jobs: filling, storage, and emptying, and you need it to be able to do all of those jobs in order to maintain continence. So for normal urinary control, it is regulated by the brain and the spinal cord. The brain sends signals causing the bladder muscle or the detrusor to contract, and then the urethral urinary sphincter relaxes, and this causes the urine to leave the body through the urethra, which travels through the prostate. So in men, there are a number of mechanisms of continence. First, you need to have a stable functioning bladder, a bladder that's going to hold. Then you have the internal urinary sphincter, which is my little wiggler doesn't work, but there's the bladder neck sphincter, the internal urinary sphincter. This is an involuntary smooth muscle controlled mechanism. Then there's the pressure provided by the prostate and the urethra, and then the external urinary sphincter, or the rhabdo sphincter, which is a striated muscle complex. And this is predominantly made of slow twitch muscle fibers. And this is important in having endurance because it's a muscle that stays contracted most of the day, with the exception of when it relaxes to void. Pelvic floor muscles are also predominantly slow twitch muscles, and this plays a role going forward. So in a radical prostatectomy, regardless if it's performed open or laparoscopic, robotic, the prostate and the seminal vesicles are removed, and the bladder is joined to the end of the urethra. And so what this does is this shifts the angle of the bladder and the urethra. You lose the mechanism of continence provided by the internal sphincter, as well as the prostate. And there can be damage to the external urinary sphincter through surgery and the pelvic floor muscles, affecting the neurovascular bundles. With radiation, it can also affect the anatomy and function of bladder control, but differently. So with radiation, whether it is external beam, brachytherapy is pictured with these little seeds in the prostate, or saber, it's targeting the prostate to kill the cancer cells, but there could be some radiation that escapes, causing damage to the bladder tissue, the urethra, pelvic floor muscles, the sphincter, and potentially even the rectum. So when we talk about incontinence, as a urologist, I like to break it down into types of incontinence because this influences our treatment options. So stress incontinence is the loss of urine with activity, sneezing or coughing. And this is what we see most of the time with radical prostatectomy, at least in the beginning. Urgency incontinence is the leakage which is accompanied or immediately preceded by that desire or urgent need to run to the toilet. It can be also referred to as an overactive bladder. Mixed incontinence is the loss of urine with urgency, but also with the stressed provoking maneuvers, such as sneezing or coughing. Overflow incontinence is leakage of urine, which is associated with urinary retention. So you can't empty the bladder, it's too full. It's like the big pot of water that just spills over. And total incontinence, it just refers to the continuous leakage of urine. So in order to sort out this problem, we have to come to a diagnosis and a treatment plan. So what I typically ask people, or what I want to know, is typically, when did the urinary incontinence start? How often are you urinating during the day? How often at night? Do you have to rush to the toilet? Are you wearing pads? If so, what type? How many? How wet are they? Are you changing your clothes? How is your urinary stream? Do you feel empty? Is there any neurological stuff going on? Have you had a stroke ever? Is there Parkinson's disease, MS? Do you have a pinched nerve in your back? Have you had surgery or radiation? And then what are the bowels doing? What's this doing with your sexual functioning? Are you on any medications? What's making it worse? What's making it better? What have you tried? And how much is impacting your quality of life, or how bothersome is it for you? Because that defines what we do next. This includes an examination, and it's not always the let's strip and check out the area where the leakage is happening. It's more subtle things than that. It's You know, does it look like there could be memory problems? Do you have arthritis in your hands? Are you coming in with a walker or a wheelchair that you can't make it to the toilet quickly enough? You know, are there rashes on your skin from being damp? You know, it's a whole variety of things. It's a whole person, not just the penis and the genitals. So then I typically use voiding diaries as a tool, and this helps me gauge where the incontinence is coming from and if there are any modifiable factors for it. I typically like to perform a urine test. This rules out any blood in the urine, any infection. I like to rule out diabetes or see how well the blood sugars are controlled, get an idea of the kidney function, what's going on with the PSA, especially if we're concerning the setting of prostate cancer. And then to assess bladder emptying, I like to do a Uroflow, which is a pee test where you urinate into a special machine and it measures the flow and the amount that goes into this little beaker. Our kidney bladder ultrasound will also give us helpful information about bladder emptying, and we'll talk about these other two things in just a bit. So avoiding a diary is a huge nuisance, and I do apologize for it, and I wouldn't make people do it unless I thought it was helpful. So you have to record what you drink, how often you drink over a 24-hour period. And in, oh, it says my internet connection's unstable. Okay, so anyway, so you want to know what you're doing. And in prostate cancer incontinence, I do like the pad weights more than I do on a day-to-day basis, because depending on the degree or the volume of incontinence directs some of the surgical treatment options. So I wouldn't make people go through this horrible test if it wasn't for that, because it really is a nuisance. So what I ask people to do is get a large Ziploc bag, put a dry pad in it and seal it up. Then that's a brand new one. And then you have another big Ziploc bag, the exact same size. And then after you've used it on the day that you're recording, you seal that one up too. And however many you use, you have to stick with the same style of pad. Otherwise, my weights are going to be off. And then you write down the numbers and you can bring it into the office and then I weigh it for you so you don't get in trouble by ruining your kitchen scale at home. So when they talk about degrees of incontinence, typically mild incontinence is less than 100 grams. High or severe is more than 400 grams. But the definitions of this are not particularly standardized. It still depends on where you look. So cystoscopy, I consider it kind of the tool, like a stethoscope of the urologist. It gives us a lot of information. I was making this presentation and my husband goes, "Why'd you put that picture in there?" But it does give us very helpful tips. So the cystoscope is a little camera that goes up the urethra into the bladder, and it helps us identify bladder tumors, which can cause frequency and urgency. It helps us find bladder neck contractures. See that little pinhole in the corner of the screen? And that's where the bladder joins to the urethra. And that needs to be treated before we go about fixing issues with incontinence, because it's going to be blocked off if you do anything about it. So you need it nice and stable. It also gives us clues about what's the sphincter muscle doing. So in the lower picture here, you can see the gaping lumen of the urethra. And then you ask the patient to squeeze, and you can actually see those the external urinary sphincter squeezing. And this is a very good prognostic sign for someone who's considering a sling operation. You can also do maneuvers where you push right under the scrotum where this area is. And if that area moves, that's also a good sign. So urodynamic studies, they are typically done in the hospital, and they're a bit cumbersome and unpleasant as well. So my apologies. It involves a tiny little catheter that goes up and through the penis into the bladder. another tiny little tube that goes into the rectum, and little sticky electrodes that go on the perineum. And what this test does is it looks for unstable bladder contractions. It gives us information about how good the urethra seals during filling, and it also sees what's going on with the bladder during voiding. So is it obstructed? It gives us information about the post-void residual as well. So the choice of treatment really depends on what type of incontinence it is, the degree of bother, the person's goals, expectations, other health issues, prior surgeries, and a risk versus benefit type situation. So regardless of who I'm talking to, you really want to adopt some healthy bladder habits. You want to have a healthy voiding frequency, so you're not spending all day in the toilet, but only voiding 1 or 2 times a day is also not normal or very healthy for you. You want to avoid bladder irritants. You want to avoid constipation, stop smoking, healthy body weight, pelvic floor exercises, be fit. So this is a really good way to actually help your bladder control. You need to drink enough water, which is a bit counterintuitive for people who feel like they spend too much time in the toilet. So you don't want to drink too much that you're there all the time. But if you don't drink enough, your urine is super duper concentrated, and that will lead to bladder irritation, can lead to urinary tract infections, and you can actually trick your bladder into having a very small capacity. A good strategy is reducing the fluids in the evening so it doesn't disturb your sleep. Now, avoiding bladder irritants is kind of tricky, and sometimes I feel like I'm a big meanie because I say don't do all the things that people enjoy. So that's drinking coffee, having a glass of wine, even pop. But these sort of things, unfortunately, irritate our bladder. So the key is moderation. You just really want to avoid excess. Sugars and artificial sweeteners are also bad. So if you like it, it probably is on the list. You want to have good bowels, because if you are constipated, it'll interfere with bladder emptying. And you try and do this with adequate water intake. You really want to stop smoking, either nicotine or marijuana, because both things can cause you a cough. Both are irritating to the bladder muscle, and maintaining a healthy body weight is important because having a high body weight increases the pressure on the abdomen, making both urgency and stress incontinence worse. So myths about bladder control that I want to bust. So restricting fluids will result in less leakage. False. I kind of alluded to that one already. So if the urine's too concentrated, your bladder's going to have more spasms. So next one. If you urinate more frequently, you will reduce the incontinence and you'll regain your continence more quickly. I guess this is false too. So you really want to train your bladder to hold the normal amount of urine. So you want to kind of go every 1.5 hours and not much more than that, because otherwise your bladder never learns how to be full and do its proper job. Now, stopping your flow of urine while urinating is good to help with control. This is false too. It can lead to voiding dysfunction. Now, I'm glad I answered this one the way that I did, because I didn't realize how involved the pelvic floor physiotherapists are here. But you know how to do your pelvic floor exercises correctly. So in this room, it probably is yes. But in the general crowd, it's probably more of a maybe. So they say about 70% of men who come to see the pelvic floor physiotherapist come there with the wrong muscles. So they're either squeezing their abdominal muscles, their buttocks muscles, their breath holding, or doing something with their diaphragm, and nothing with the pelvic floor muscles at all. But you guys have had lots of sessions with the pelvic floor physiotherapist, so maybe it's only 1 out of 10. All right, so pelvic floor exercises. They're very important because After a prostate is removed, it's really the external urinary sphincter and the pelvic floor muscles that you have to work on to build strength and endurance to get that bladder control back. Now you want to focus on tone and quality rather than quantity, because with any sort of exercise, if you do too many of them, you're really kind of sloppy at the end and you're probably not squeezing the right muscles. In town, we're very lucky to have a very good group of pelvic floor physiotherapists. And it's really actually a very extensive list of physiotherapists in town. And they have special tools like biofeedback where you can, it's kind of like a computer game where you can engage the proper muscles. And there are studies that show very easily that there is benefit in performing these exercises with coaching and help of both physical therapists and biofeedback. So how do you find the pelvic floor muscles? I think step one, first, find the pelvic floor physiotherapist or go to one of the group sessions. So the pelvic floor contraction is really an inward type of lift, a squeeze around the urethra, which results in the urethra closing and resisting downward movement, which could lead to incontinence. And the way to know if you're doing it properly, you can try and draw the testicles into the pelvis, pull up the penis toward the body or try and shorten it, squeeze the muscles as if you're stopping the urine, but don't do this when you're actually voiding, and tighten the anus is another strategy. But I think the biggest bang for the buck is pelvic floor physiotherapist through your session, because that's a lot cheaper than the community. All right. So there's various strategies to cope with urinary incontinence. People typically shift out of wearing light colored pants. Sometimes they have little odor eaters. Sometimes they bring a change of clothes in the car or have a bottle in the car. But there are a variety of products that are very, very helpful in managing incontinence. So there's disposable and reusable options. They come in pads and briefs of various thicknesses. And I think the reusable ones are increasing compared to when I started practice 10 years ago. So there's clamps and cuffs. And in order for these to be a suitable option, you have to be able to put them on and open them. Otherwise, that's a bit of a problem. That would be an unfortunate trip to the emergency room. You want normal penile sensation. You don't want to have any sores on the penis, and you want to have awareness of bladder filling. So you ideally don't want to wear a clamp for much longer than a couple hours to avoid risking urinary tract infections. And you certainly don't want to have it overnight, but they are a useful strategy for people who like to go on hikes. So there's a variety of devices. Dribble Stop, which can be ordered online, is pictured in the upper corner, and the Cunningham clamp, which is the more medieval looking device, but there is still a spongy modifications. That one is the cheapest one. There's a Pacy Cuff, which works by providing circumferential pressure onto the urethra. The Acti Cuff is a disposable option where you put the penis into the little sachet and it clamps around, and that's more for lighter or moderate incontinence. There's another device called Cantino, which is fairly new. It's a small plastic insert, which is put into the urethra. And then when you want to void, you simply remove it and empty the bladder and reinsert it afterwards. The benefit, I suppose, with this is less environmental waste. It's not ideal if somebody has like a damaged urethra or very prone to urinary tract infections, but it is a newer option. There's condom catheters, which can be helpful for patients who have heavier degrees of leakage, sometimes helpful for travel. It doesn't require as much manual dexterity. It is inconvenient if it slips off. It can also cause some irritation of the penis. And I really don't care for indwelling catheters to manage incontinence because they can cause all sorts of damage, bladder stones, urinary tract infections, and really distorted and unhappy tips of the penis because it causes erosion on the ventral surface of the penis. So I thought I'd be kind and just leave that image out. So overactive bladder or urgency incontinence tends to happen more with aging, as I had alluded to, but also with patients who've had radiation. So treatment options for this include adequate hydration with water. You want to avoid bladder irritants and stress. Stress is a bladder irritant. There's certain urge suppression techniques, such as taking a deep breath, sitting down, trying to engage the pelvic floor muscles, pelvic floor exercises, medications, neuromodulation with, say, neuromodulator or tibial percutaneous stimulation, and maybe even some role for acupuncture. So when we're looking at medications for urgency incontinence, the anticholinergics are the most common one. They're the older class of medication, and unfortunately, they do have some nasty side effects, including dry mouth, constipation, blurry eyes, dry eyes, and it can also cause some issues with cognition. So not really an attractive solution to the problem. They say about 1/3 of patients will carry on with it even when it's effective because the side effects are unpleasant. There's a newer medication that's not all that new. It's a beta-3 agonist. It works by promoting bladder relaxation, so storage that way, whereas that other family inhibits the contractions. In Canada, we only have one of these medications. In America, there's another variant. Potential side effects include high blood pressure, palpitations, stuffy nose, headache, urinary tract infection. But fortunately, these are rare and it is tolerated better. The major downside is the side effect of what it can do on a person's pocketbook. Bladder Botox is very effective, particularly more for the nighttime urgency and frequency compared to some of the oral medications. So it's from the neurotoxin Clostridium botulinum, and it blocks the nerve endings that cause the bladder spasms. So we perform the injections cystoscopically into the bladder wall under direct vision, and the typical treatment dose for an overactive bladder is 100 units. It does require repeat treatment, typically kind of 5 to 9 months, no sooner than 3 months. And you really want to empty the bladder well, unless you're managing with catheters already. Potential side effects include urinary tract infection, urinary retention, hematuria, or very small risk of systemic weakness. Now, for post-prostatectomy stress urinary incontinence, here's this little graph, which I'm trying to indicate that when the catheter comes out, it's mostly universally quite a wet time. And so I always tell patients when I'm removing the catheter in the office to bring Depends, bring a pad, and if they didn't, then I make sure I give them some, because people are generally very wet when that catheter first comes out, and they are still very wet going forward for some time. To mitigate this, I try and get patients to do those pelvic floor exercises before surgery so they know where those muscles are. There's no real point of doing them with the catheter in, that just kind of irritates things. But when the catheter comes out, it's a good time to restart them. Now, very rarely, thank goodness, there can be hypercontinence. So when the catheter comes out after the prostate is removed for the first time, if you're unable to urinate, that's an actual medical emergency, and you have to go to the emergency room. But you don't want to have an emergency doctor put a catheter in, because they could damage that beautiful anastomosis that has been created, and then that could lead you to have some major problems. Anyhow, I digress. So with time, thankfully, bladder control improves. So at about the 1 year mark, less than 10% of patients following radical prostatectomy have more than 1 gram of urine loss in a 24-hour period on the pad weight test. They estimate about 2% go for surgery for post-prostatectomy incontinence. So there are some risk factors for post-prostatectomy incontinence. So this is more that stress type of incontinence. This includes advanced age at time of surgery, pre-existing urinary incontinence or an overactive bladder, resection of a neurovascular bundle or a non-nerve-sparing procedure, presence of an anastomotic stricture, which can happen if there's a urine leak or a big hematoma, obesity, if the prostate's very large, if the person's had radiation in the setting of, say, like a salvage prostatectomy, where you have radiation first and then your prostate removed, having a previous bladder outlet procedure like a TURP, and sometimes people just have shorter membranous urethras, and that would be a risk factor. So for surgical treatment options of post-prostatectomy incontinence, there's bulking agents, but these don't work well. They are less invasive, but they're costly and they don't work well. I don't really know of anyone who uses them anymore because they're so ineffective. They also pose risk for infection. Perhaps if there is some newer effective agent which didn't dissolve or migrate, it might be a helpful solution someday. There has been some talk about stem cells, but it's not really a true option, but you do see it on some lists. So the Proact is also not really available. It's not covered in BC and it's not available here. But what it involves is adjustable balloons inserted in the perineum, just underneath the bladder neck from where the prostate used to be. And what this does is extends the length of the membranous urethra to help with the control. So as far as improvement rates, I think it's around 66%, but they do have a high rate of complications and explantation. So that's 24%. So that's 1 in 4 people, which is not so ideal. And you don't really want to risk, severe complications, but it's not available for us here. I had a bit of experience when I was in Australia with it. The fixed male slings are another option for patients. This is the first actual surgical option that I'd consider. And so this, the Advance XP is a transobturator sling. It works for mild to moderate incontinence. And the way it works is by relocating the dislodged urethral sphincter and the posterior urethra back into its original location. And this increases the urethral functional length, helping with continence. Prior to this sling, which came out around 2010, there were more bone-anchored slings. And the problem with them is they were less effective and they had higher complication rates. But with these ones, it's actually a short surgery, little incision made in the perineum, the space behind the scrotum and in the inner thighs. And it works quite nicely when patients are properly selected. Risks are urinary retention, chance of having perineal or inner thigh pain, and they have rare rates of erosion. The quadratic sling or Virtue sling has a similar efficacy compared to the other sling I was showing. It has an extra set of arms And that is thought to provide pre-pubic compression and perhaps improve the rate of success, but it's really not that much more effective. And there are more cases of perineal pain and mesh complications because there is more mesh. I don't think anybody on the island offers this, and I'm not sure if around British Columbia the Virtue is very popular either, but so patient ideal characteristics for the male urethral slings. And the reason why I called them fixed slings in those other slides is because once they're in and they're working and you don't have to do any fiddling around. So ideal characteristics would be the absence of fibrosis or radiation scar or scarring from cryotherapy. You want to have mild incontinence, so less than 2 pads a day, less than a 150, 200 grams and a 24-hour pad weight. Ideally, we like to see that the external urinary sphincter contracts volitionally, and we assess that at cystoscopy. We save this for patients who have not had previous anti-incontinence procedures, and we want to make sure the bladder is actually emptying quite nicely. So there are adjustable slings. Adams is an option that is done here on the island. I don't offer this one because both Dr. Hogue and Kinahan already do. But the advantage for this one is it works in repositioning the urethra similar to the fixed slings, but it also has a cushion underneath the urethra which applies pressure. And if a person is still quite incontinent following the surgery, at a later date you can inject some saline to bulk up the balloon and apply more pressure. So it has that advantage of, you know, another try at things, so to speak. It can be used for patients who have had radiation, which is a big advantage. You don't need to do any special manipulations in order to void, so it can be useful for the elderly or someone who has issues with arthritis. But they do have higher rates of needing explanting due to infection because it's a bigger foreign body. So the artificial urinary sphincter is considered the gold standard. It came out around 1973, and it has three components. So it has an inflatable cuff around the urethra, a control pump in the scrotum, and a pressure regulating balloon in the abdomen. And they've had about 5 versions of this device, and the latest one was the non-kink tubing, which isn't really all that new anymore. It's been like that for ages, it seems, so it hasn't changed much in the last little bit, but it does work very well. So in order to operate it, you squeeze the pump in the scrotum, and this causes the cuff to shift the fluid back to the regulating balloon. It opens up the urethra, you void, and away you go. It will close back on itself. And it's discreet. You can use it at a urinal with not very many people noticing at all. It's a nice device. So what makes it, what do you look for in somebody who would be a candidate? So you need to have good hand control, and you need to have the mental capacity in order to operate it yourself. Otherwise, it's just too tricky. So if people were to get dementia after it's been in, oftentimes we deactivate it to prevent injury or erosion. You have to have a bladder capacity of at least 200 milliliters. You want to make sure the bladder empties well. You have to have a decent flow rate. That's at 10 milliliters per second. And because there are some more significant complications, it's a bigger surgery, you really want to make sure you're up to having surgery. So you want the benefit to exceed the risk or the fears. I think it's contraindicated and people can operate it. If somebody has a bad scar in the urethra or bladder neck contracture, you really need to have that corrected and treated first. If somebody's high risk for infection, not ideal. Similarly, if a person had like a spinal cord injury and high pressure bladder, if you put one of these devices in, it could do damage on the kidneys. So you want to make sure that there's no major voiding dysfunction. And if somebody has a need for repeat urinary surgeries like bladder tumors or major kidney stone history, you get worried the more times you have to go in and out because you don't want to damage the device or the urethra. So complications, I think a way to avoid this is getting a medical alert bracelet so people don't jam a catheter into a closed sphincter, which is probably one of the main reasons why they have issues sometimes. That's completely preventable. So after they're put in, you can have urinary retention. If the device becomes infected, it's usually a staphylococcal bug like Staph aureus or Staph epidermidis, a skin bug, and you have to remove the entire device. So the reservoir, the cuff, and the pump. Erosion, that typically happens in the setting of trauma, I think, and or patients who have radiation. And if this occurs, you want to remove the device, repair the defect, and come back later. Mechanical malfunction. So life expectancy is typically around 7 to 10 years, but there's some very old devices out there, some that are like 25 years old, which is great. I think I read one study that said about 40% are still functional at 15 years, which isn't bad. You just don't want to get the lemon, but they all work pretty good. With time, if the cuff is always turned on, the urethra can get a little bit atrophic or get a little bit skinny, and there may be some recurrence of incontinence, and there is a chance of needing revision, which is not negligible. So as far as new innovations, there are some other devices available. They're not easily accessible in Canada. The one I have pictured up in the corner is the Victo device, and it has a little area where you can insert more fluid to adjust the pressure on the urethra and shift it, but it's not really here yet. And then they always talk about, being able to control your sphincter with a smart feature. So whether it's magnets or, a Bluetooth or whatnot, but they're not there yet. So hopefully they come with something more magnificent soon. So in summary, urinary incontinence can be a reality for many patients with prostate cancer. There's certainly strategies to cope with it and even treat it. I do recommend conservative measures first, and time will actually settle out most, or at least get you down to perhaps considering a sphincter to maybe having a very successful outcome with a sling, or not needing nothing at all. So surgical treatments, they offer effective, durable results for post-prostatectomy incontinence. And I really hope that this is kind of a starting point, or where you feel more comfortable or informed about incontinence management, that you can talk to your friends about it, consider speaking with your health care provider, and do something about it. I did bring an example of the artificial sphincter and the sling, so we can show them off later on. But I think we're going to go to questions.